Hi everyone, and very good evening to all of you guys. Hello everyone, guys. A very good evening to all of you. For those who joined the session live, the one-shot FMG pathology series, and I'm very sure that this will be very helpful for those who are preparing for the FMG. And I think my audio and video is quite clear. Please let me confirm your side also if if there is any issue. I can just sort it out. From my side, everything looks fine and perfectly okay. I just want you to confirm the same thing from your side. If there is everything fine, am I audible and I'm clearly visible as well. Um, so guys, this is basically a session to talk about the most important things that we should be covering for the one shot FMG. For those who joined me live on YouTube, guys, please just give me a big hello. Hi, for this unusual names, I don't know how much I will be able to take your queries. So, but if you have a real name, yes, and you surely should have. So please let me know what your real name is. But hi, Swiss. Hi, Nidhi. Hi, Hari. Hi, Sangeshwari. Hi, very good evening to all of you. And for those all of those who are joining me live, it's really immense pleasure to have you all today. And in this today's session, we'll try to revise entire pathology in just around 1.5 hours to 2 hours. I'll not stretch it because your exam is just around the corner. And I would say that about this PDF I've given to you, the PDF basically all you can get this PDF. Just click this link. It's my Telegram group link, and once you click it, you have a already uploaded PDF there, and you can also download it as a read for you going ahead. Uh, since it's a one shot series, I wouldn't be very slow here. I would be a bit faster. A few disclaimer I'll just tell you. It's a high yielding notes. Prepare in keeping view the high yielding and the updates of FMG exam. It's better to take a printout, and I will very well share this PDF also to you at around 2:30 p.m. today in my own Telegram group. And use these notes along with the main notes. That means this notes should not at all. Please let me know let me make it very clear. None of you should take these notes to be replacing your main notes. Your main notes is your main notes. Is only to help you to revise entire thing in less amount of time. I may again repeat, this is not the main notes. Please refer to your main notes just to revise the entire pathology in just 1.5 hours. Okay, so with that intent, and those who have joined me again more live, hi Pooja, hi Hari, hi Satya Reddy, Muskan, and Rocky and Surya. I think two people are watching this together. That's a funny combination, but yes, it does happen. So, guys, let's start the entire session. So I'll just divide the entire session into three parts. One is a general pathology, next is the hematology, and the lastly we'll cover the topic of systemic path. Okay, so with this, let's start the session, guys. Okay, starting with cell injury. In cell injury, the question that can be asked is about the reversible injury, and that is about the hydropic change. Now, this in front of me is a Mickey Mouse image where a normal cell, when it has a reversible injury, it undergoes increase in cell size. The upper surface, the blebs are formed, and on the upper surface, the villi are completely lost. So, what to expect in the reversible injury is loss of microvilli, bleb formation, and cytoplasmic organelle swelling. The two organelles that is often asked here, one of them is mitochondria and one is the endoplasmic reticulum. And because of the ER swelling up, ribosomes often separate out. So these are the findings that you expect in a reversible cell injury. In light microscopy, when a cell swells up, normally a cell stains pink and the nucleus stains blue. But when a cell swells up, what happens? There is cell swelling. The color becomes more and more pale. The pale color cell is called as hydropic change. So two questions can be asked. Number one, you should remember what is the electron microscopy image, and I think you can all remember this Mickey Mouse image. Cell size increase, outer cell blebs, loss of microvilli, nuclear condensation, and organelle swelling. Do you remember when you see this in light microscopy, the color of cell is more towards pale side. The pale color cell is often referred to as hydropic change. Okay, hydropic change. Next is the example of necrosis. See, necrosis can be coagulative or liquefactive. Okay, one more thing, guys, just share this video so that all of your friends who are preparing with us can also come and watch the session live. So now, wherever your groups are, please share this video, and I'll ask all of them so that we can all cover and complete pathology today in just 1.5 hours. I don't think there's any more golden opportunity to cover the subject entirely in just 1.5 hours. Okay, so please do that. Okay, example of necrosis. So first of all, there are some names for necrosis. One is a tombstone appearance, moth-eaten appearance, and a glassy appearance. The main examples where you see this example of qualitative necrosis, which often is the most common type of necrosis, is ischemia to all organs. The only exception here is the brain. There's dry gangrene, Zenker's degeneration, and thermal injury. The second most common type of necrosis is a liquefactive necrosis, also called as colligative necrosis. This necrosis is seen in ischemia to the CNS. It is also seen in any type of qualitative necrosis. Along with that, if there's a bacterial infection, and therefore, often a question will see dry gangrene is type of coagulative, but when the example is a wet gangrene, okay, wet gangrene, it's a liquefactive necrosis. It's a liquefactive necrosis. I'll again repeat for those who don't have a PDF. This PDF is already uploaded today at 2:30 p.m. Today itself in my group, and you can just, if you don't have it, koi baat nahi, you can just take the PDF from my own Telegram group. The link of which is in the first part of this video. About the types of necrosis, one is caseous. This is very frequently asked question, guys. It is seen in tuberculosis, histoplasmosis, and coccidiomycosis. Tuberculosis, um, histoplasmosis, and the coccidiomycosis. Fatty necrosis is acute pancreatitis, and trauma are the two main examples of fatty necrosis. The example of pulmonary necrosis, it's often seen in vessels due to three causes. If a vessel has an immune complex deposition, if a vessel has an inflammation called as vasculitis, and a very high blood pressure called as malignant hypertension can also lead to fibrinoid necrosis. Okay. Images I already have covered yesterday in the separate image session. So those who have not seen that session, please go back and also see every image that is important for you in this session. I've discussed with you already in the previous sections. Okay. So I've discussed with you hydropic change, necrosis of coagulative, liquefactive, सब कुछ पढ़ा चुका हूँ. So dry gangrene, wet gangrene. Remember, dry is type of coagulative, wet is a type of liquefactive necrosis. This is a very frequently asked image where you see a white cheesy deposition, and when you see a multinucleate giant cell, the whole thing becomes a granuloma. So remember, they can also ask you white cheesy deposition showing you this type of necrosis. So when you see a complete pink color, it becomes a necrotic granuloma. Okay, completely pink color becomes a necrotic granuloma. Necrotic granuloma. Okay. Coming ahead, look at this fatty necrosis. It often shows a chalky white deposition in the gross morphology. So on the upper side, you can see this normal fat deposition, normal all fat globules. On the lower side here, what you see on this side is a fat necrosis. This whole thing is a fatty necrosis. And what you see is due to saponification. This whole process is called as saponification. The whole process is called as saponification. This is what type of necrosis? Anyone? This is what type of necrosis? Anyone? Yes, it's example of fibrinoid necrosis. Okay? Chalo. Next is apoptosis. Apoptosis means a programmed cell death. Okay, that's the first question that can be asked from this. Secondly, they can ask you the two pathways of apoptosis. What happens is when there is an injury, injury is first sensed by BIM, BID, BAD, NOXA, and PUMA. BIM, BID, BAD, NOXA, and PUMA. What they do, they increase those genes which are pro-apoptotic, like BAC and BACs. And any gene which is an anti-apoptotic will have a letter L inside it. L. Genes like BCL, BCLXL, MCL, these all L wala genes. These are anti-apoptotic genes. And what they do, they will decrease in number. So when this happens, what happens? Cytochrome C leaks out, which combines with APAF1, and the whole combination is called as apoptosome. This apoptosome would activate the cytochrome C, and they also activates the caspase. So once because it's an intrinsic pathway, it activates caspase number 9, which activates caspase number 3 and 6, which is the executioner caspase. Once the caspase forms, what happens? From the main cell, an apoptotic body forms out. the body would separate out and is engulfed by the macrophage by a process referred to as efferocytosis. This happens in the intrinsic pathway. What happens in the extrinsic pathway is, suppose this cell has to be destroyed. So this cell is a self-reacting lymphocyte, and this suppose is a T regulatory cells. So what happens? T regulatory cells destroys self-reacting lymphocytes. A Treg cells, they have a TNF. They activate the TNF receptor on the self-reacting lymphocyte. Once a FAS is activated, once a FAS is activated, the FAS would then activate a FAD, and once a FAS activate FAD, it will activate cascade number 8. How to number 8? E for extrinsic, E for 8. Okay, this 8 would activate 3 and 6, and ultimately this will lead to apoptosis. Okay, I think it's very clear. Now comes the difference. How would you identify any apoptotic cell? To identify a apoptotic cell, the cell size should be shrunken, outline should be intact, nucleus should be condensed, inflammation should be absent. There are 4 findings of apoptotic cell. This is a very frequently asked question. Okay. Chalo. Next we move to the inflammation. In inflammation, we'll talk about the acute and the chronic inflammation. First of all, I'll discuss with you the 2 main events of the inflammation. In the vascular event of inflammation, there is a vasodilation and there is an increased vascular permeability. Okay, because of these 2 things, there is a histamine coming out, and histamine comes out from the mast cell. Okay, histamine comes out from the mast cells. Now, this is a cellular event of inflammation. What happens here? Suppose this is an endothelium. Okay, and the neutrophil right now is in this part. The first thing that happens is neutrophil should first come to the margins. This first step is called as margination. Okay, this step is called as margination. It then comes to the rolling, then it comes to the adhesion. From adhesion comes to diapedesis. There is a chemotaxis, there is a engulfment, and there is a destruction. All these steps we'll see one by one. The first step का नाम बताओ. All of you say with me, margination. सब मेरे से बोलो, they say with me. Okay, margination, rolling, adhesion, diapedesis, chemotaxis, phagocytosis, and killing. ठीक. Now we'll take the steps one by one. First step का नाम है margination, often caused by vasodilation and selectance. Okay. Second step is rolling. How to remember rolling? S for selectance, S for sialyl, levis, X glycoprotein. Next step is adhesion. Adhesion के लिए ICAM and VCAM. How to remember this? SCAM full form होता है cell adhesion molecule, and hence CAM should cause what? Cell adhesion. And adhesion molecule should do what? Integrate, and hence what is this molecule called? Integrin. So remember, sialyl levis with selectin is helpful in rolling. Integrins with ICAM, VCAM are helpful in adhesion. Next step is the diapedesis, and both the molecules on the neutrophils and the endothelium, they both are PCAM1, also called as CD31 molecules. ठीक है, first step हो गया. Just remember few things. If there's an absence of beta-2 integrin, there's a problem in adhesion. Such disease is called as a leukocyte adhesion defect 1. But if a patient has problem in the sialyl levis X glycoprotein, this is called as leukocyte adhesion defect LAD2. Okay. Now will come the 5th step. The 5th step is chemotaxis, often caused by chemokines. So how to remember chemokine? If suppose I am attracting you, I would say to come here. तो इधर आओ, है ना? C5A, A से आओ. When you come here, I'll ask you to stand before me. So leukotriene before, LT before. Apart from this, interleukin 8 and bacteria are also a good amount of chemokines. Next is phagocytosis. In phagocytosis, there is 3 steps: recognition, opsonization, and killing, and engulfment. First, to recognize, they're not very important, just leave it out. Then we move to opsonization caused by opsonins. Opsonin is a very frequently asked question. Examples are complement. So remember, C5A is a इधर आओ, वो chemokine था. C3B, C4B, C5B is a opsonin. Okay. Apart from them, the FC receptor of IgG. Then there is a C reactive protein and fibrinogen. These also are good examples of the opsonization. So what is opsonization? Imagine this is a samosa, and I want to eat a samosa. So what I do, I put a samosa on a chutney. Chutney से क्या होगा? I want to eat it more. So when I increase the taste of an antigen, how can I increase the taste of the antigen? By adding the antigen, by adding this antigen to this antibody. And who is the antibody here? IgG antibody. There are four good examples of opsonins. मेरे साथ बोलो, all of you say with me. C3b, 4b, 5b, IgG, C reactive protein and fibrinogen are the four good examples of opsonins. ठीक है, अच्छा. नेक्स्ट स्टेप क्या है? समोसा कहाँ है? चटनी के अंदर. And I wanted to eat it. So this samosa will come here. This movement of the samosa from the chutney towards my mouth, it is called as opsonization. So when the samosa is here, what I do? I open my mouth. Look at my mouth is open. It is called as engulfment. तो engulfment के बाद क्या होगा? The samosa would enter a vacuole. The vacuole is called as phagosome. To the phagosome, a lysosome will fuse to it, and this whole combination is called as phagolysosome. This fusion is caused by LYST, Lys gene, and the Lys gene is an autosomal recessive trait. If this is absent, very frequently asked question, it's a Chidiac-Higashi syndrome. क्या है इसको? Chidiac-Higashi syndrome. Okay, चलो. Next, you move to the next step. It is called as step of killing. In step of killing, what happens? There is an oxygen dependent and oxygen independent mechanism. Right now I'm discussing with you oxygen dependent mechanism. Very important. What happens here? The first enzyme we'll see is a FOX gene. The FOX gene is basically a name which comes from phagocytic oxidase. तो क्या नाम है? FOX gene है. The FOX gene, it converts oxygen to superoxide. Okay. Superoxide पे what acts? Superoxide dismutase to make what? H2O2. On the H2O2, then when the Fe2 plus acts, it makes Fe3 plus and hydroxyl. This whole reaction is called as Fenton's reaction. Then what happens? On H2O2, MPU and halide will act to make hypochlorite ion. Hypochlorite ion is the most efficient bactericidal action, and below this, most efficient free radical system is H2O2, MPU and halide system. Very frequently asked FMG question also was asked in this January FMG. Question क्या पूछा था? If FOX is absent, तो what disease will happen? Answer is CGD, chronic granulomatous disease. CGD, chronic granulomatous disease. CGT. This was a January FMG question. In the questions, they can also ask you how would you diagnose CGT? इसके तीन आंसर होते हैं. Number one is nitro blue tetrazolium chloride assay. Second is cytochrome B reduction assay, and third one is dihydroprodamine assay. The dihydroprodamine was the last year July FMG question. ठीक है? Just remember all of my points. Also remember, if a patient has a problem in the FOX and the disease is chronic granulomatous disease, then they can lead to increase in the Staphylococcus aureus infection, which is a catalase positive organisms. ये सब याद रखना चाहिए for the CGT. ठीक है? About the chronic inflammation, remember a very important cytokine which can be asked in chronic cytokine is a interleukin 12, interferon gamma, and transforming growth factor beta, TGA beta. Among them, TGA beta also induces repair. TGA beta, it also induces the repair mechanisms. And what do the chronic inflammation lead to? They lead to granuloma. In the granuloma, they have asked you what is a modified macrophage? Answer is epithelioid cell. What is a fused macrophage? Answer is giant cell. And what to see a macrophage in tuberculosis? Which tuberculosis? It is a Langhans, not Langerhans. Yes, Langhans giant cell. The whole collection of a lymphocytes, epithelial cells, the whole collection of a lymphocyte, epithelial cells, macrophage, giant cell, epithelioid cells, these all are called as granuloma. Among all of them, the first and the most important cell which is involved here is called as a macrophage. Okay? Okay. NET was also this last January FMG question, NET. What happens in NET is a neutrophil extracellular traps. In severe infection or sepsis, what happens? Neutrophils, it will activate the chromatin, and after chromatin is activated, arginase action would lyse it. Once it lyses, all fibrils comes out, and when fibrils comes out, it will lead to the microbicidal action, and this action will destroy every antigen there. Because of the anti-DNA antibody will increase risk of SLE, and it also is called as suicide benefit. Okay, what they asked you is, does NET involve phagocytosis? No, that's an answer. Okay, there's no phagocytosis involved in NET, because in NET destruction of antigen occurs because of destruction outside the neutrophils, not inside the neutrophils. It occurs outside neutrophil. That was a question in the January FMG exam. Okay, that's a neutrophil extracellular traps. So till now I've discussed with you 3 chapters: cell injury, inflammation, acute and chronic. All of you tell me, are you all following it? Please let me know. So hi, Satya, Muskan, Rocky, Arun, Neha, Hari. I would suggest that if you listen to me very carefully, I can assure you that all the 20 questions will from this part only. But you have to listen to me very carefully. I just want all of you not to leave the main notes. That main notes is a very important thing. Just try to follow the main notes, and along with that, this will supplement this with this type of rapid revision. Okay. So are you all understanding this, guys? Do you need me to go more faster, because slower तो चल नहीं सकते हैं, a lot of things remaining. So can I go a bit more faster? The speed is okay. PDF is already available on my Telegram group. Okay. So can I move ahead, guys? Shall I move ahead? Okay. Next chapter is the bleeding and coagulation. The first thing that happens is that there is a vessel, and on the vessel, the moment there is any endothelial injury, what will express is a von Willebrand factor. Platelet will first adhere to this by a step called as addition. This first step is A, and A is called as addition. The second platelet with the help of GP2B3A will cause aggregation. The step number B is called as aggregation. ठीक है, addition हो गया, aggregation हो गया. Now, if a patient does not have this VWF, problem is addition more than aggregation, addition or aggregation, and this is called as von Willebrand disease. If 2B3A is not there, it's called as Glanzmann thrombasthenia. And if 1B9 is not there, it's called as Bernard-Solis syndrome. If 2B3 is not there, it's called as Glanzmann thrombasthenia. About the secondary plug, remember this intrinsic pathway and there is an extrinsic pathway. What happens in the intrinsic pathway? The first thing is to activate 12 to 12A. But देखो, how to solve the questions on this pathway in the exams? In exam, I will suggest you to start from common pathway, because we all know common pathway starts from 10. If you remember 10 का हाफ कितना होगा? 5, तो 5 आ गया. 5 का हाफ कितना होगा? 2, तो 2 आ गया. और 2 का हाफ 1. तो just याद करना, common pathway is rule of half. 10, उसका half 5, उसका half 2, उसका half 1. On 1, what acts is 13A, and 13A makes a stable clot. Once clot is formed, it is broken by the plasmin to make FDP and dimer. Just remember one thing, extrinsic pathway there is only one factor, factor 7, which is activated by factor 3, and 3 is a tissue factor. In the lab, you can add thromboplastin to activate the same thing. In the intrinsic pathway, what happens? It is HNWK, which basically converts 12 to 12A. 12 activates 11, 11 activates 9, 9 with the help of 8 activates 10. So how to remember the pathway? I would suggest you to go with common pathway. 10, 5, 2, 1. Half वाला rule. Simple हो गया, okay? अब देखो, if a patient has problem in the increase in the PT, okay, PT अगर increase है, it is often factor 7 deficiency, but can also be warfarin dosage or can be vitamin K deficiency. If problem is in ABDT, just remember, ABD मतलब long name, long pathway. तो intrinsic pathway plus common pathway by ABDT, right? It is intrinsic plus common pathway by APTT. Extrinsic plus common pathway is by PT. So if a patient has increase in APT, problem is in 12, 11, 9 or 8, all of them. Extrinsic pathway mein, suppose PT is problematic, it is 7 deficiency. If both of them are there, then common pathway, and common pathway is what? 10, 5, 2 and 1. That's a common pathway there. ठीक है? चलो. We now move to the topic of genetics. In genetics, I'll first cover to you the aneuploidy examples, which are trisomy and monosomy. In trisomy, remember it is sex chromosomal trisomy and autosomal trisomy. Sex chromosome trisomy has only one example, it's Klinefelter syndrome. Autosomal में three examples है 18 E for Edward, 13 Pataus, 21 Daus. Turner syndrome में it is 45XO. Okay. Now the pattern of inheritance can be autosomal dominant, autosomal recessive, X-linked dominant, X-linked recessive, among which the most common is autosomal dominant, which percentage is 65%. Okay, 25% cases are upon AR, and these two combined is 5%. Non-Mendelian also is around 5%. Okay, among the non-Mendel, important ones are mitochondrial, tri-nucleotide repeats, genomic imprinting, and germline mosaicism. Just remember here that when the question is on genomic imprinting, examples are Prader-Willi syndrome and Angelman syndrome. Mosaicism may it is osteogenesis imperfecta, tuberous sclerosis, and achondroplasia. Okay, in the mitochondria, it is KLMNOP. KLMNOP matlab K for Kearns-Sayre syndrome, L for Leber's, M is Murph and Millas, N is NARP, O is ophthalmoplegia, and P is the Pearson syndrome. Not very important, just remember these the short forms, and that's really sufficiently enough. In the mitochondria, the very important question is only mother can transmit disease in mitochondrial pattern of inheritance, and there's something called a threshold effect. देखो in a cell the multiple mitochondria, suppose out of 100 mitochondria 20 are abnormal, would it manifest? Maybe not. That means a certain percentage of the mutation beyond which a disease will manifest. Such problematic situation is called a threshold effect. When you move to the trinucleotide repeats, what happens here is it can be codon repeats in the protein coding region or in the non-protein coding region. If it's a protein coding region, very simple, remember Huntington, hunter keeps an animal in cage. याद है ना, hunter keeps an animal in cage, तो CAG repeats होगा. Fragile X syndrome is CG repeats, इसको छोड़ दो पहले. Ataxia is a gate problem, तो gate से GA तो GAA repeats. मार्टोनिया में T है और यहाँ पर भी T है, तो CTG repeats. ठीक है. Among this, remember the CAG is which is on chromosome number 4. It codes for an amino acid called glutamine. It codes for an amino acid called as glutamine. Okay, I'll now move to the immune system. Before that, I would just ask you all, just share this video to your friends and let all of them come and we can all interact. And in case you have any doubts anywhere, feel free to ask me. Okay, I'm going by my own pace. I feel that you can understand it, but कोई दिक्कत नहीं है. If you're not able to understand this, please ask me in the YouTube. I'll surely answer you as I'm teaching also. Also, please share this video to your friends so that all of your friends can also come up and join the session here as well. ठीक है? चलो. Next is the immune system about the lymphocytes. The T cells are CD4 T cells, CD8 T cells, this gamma delta T cells, and there is suppressor T cells, and there's suppressor T cells. ठीक है? Now, suppressor T cells are CD4 and CD25, and what is the function of the cell? They suppress autoimmunity. They've asked you questions on the antigen presenting cells. Remember, the APC in the lymph node is dendritic cells, among which the mature DC is the most potent DC. In the skin, it is Langerhans cells. In tissue, it's a macrophage, also called as histiocytes. In the blood, it is a B lymphocyte, and in GIT, it is a M cells and M cells. Then let's move to the MHC, and then left to the MHC. In the MHC, remember MHC is on chromosome number 6 short arm, codes for HLA. MHC often codes for a HLA. That's again is very, very important. MHC codes for a HLA. ठीक है. Now देखो, MHC is the two types, class 1, okay, MHC is class 1 MHC and class 2 MHC. Okay, class 1 MHC is present in all cells having nucleus with platelets. MHC2 is in all APCs only. MHC1 identify all intracellular antigens. 2 identifies extracellular antigens. MHC1 presents antigen to CD8 T cells. MHC2 presents antigen to CD4 T cells. CD8 को और CD4 को. ठीक है. So how to remember this? देखो, if you multiply MHC into CD marker, it must come as 8. So MHC1 into CD8 is also 8. MHC2 into CD4 is also 8. So 1 into 4 is 8. Sorry, 1 into 8 is 8 and 2 into 4 also is 8. ठीक है. About the NK cells. NK cells are CD16, 56 and 94. How to remember? NK का marker last में 6 है. Both important markers have 6 at last. NK cell is a large granular lymphocytes and they destroy the antigen by ADCC. मतलब antibody dependent cell mediated cytotoxicity. ये है ADCC. This is very, very important. Okay. The main cell that is destroyed by the NK cell was again a January FMG question, is a virus infected cells and a tumor cell. Virus infected cells and tumor cells, these are the one which destroys the these are destroyed by the NK cells. A very important topic they often ask you is amyloid. Amyloid में the first word is very important. It is insoluble and extra cell deposition. Extracellular insoluble deposition is amyloid. Okay, the damage organs. Amyloid is a starch-like deposition. Starch appears pink. Amyloid also appears pink. Main stain is Congo red staining. Very, very important. Congo red staining. Okay, Congo red staining. It is seen by polarized microscopy. It is often shown as an apple green by references. It is a most specific finding for amyloid. X-ray crystallography is a beta pleated sheets. In the biopsy, it shows abdomen fat aspiration, which is the most convenient and the site. However, the rectal biopsy is also one other site which can be taken for a biopsy. Now, what they asked you often the short form and types of amyloid seen in this condition, like Alzheimer, is A beta. Melry carcinothyride is A cal. Insuloma is AAPP, where PP is polypeptide. Isolated atrial amyloidosis is AANP. In generalized amyloidosis, it's secondary. How to remember secondary? 2A to double A. Okay, double A. In dialysis, A beta 2M. In senile, it is wild form of ATTR, and familial, it is mutated form of ATTR. In the familial hereditary fever, it is autoimmune recessive form and often shows a mutation of the pyrin gene, which shows a serum amyloid association. Serum amyloid association disease. That's all about amyloidosis. Bolo. So, any doubts till now, guys? For more detailed version, Chicha, you must watch my videos of eGurukul. It's around 60 hours of video. You can watch that. I need to just cover everything in around 2 hours right now, so I cannot go into more details of any chapter and topic. I hope you understand that. But in case you want to learn more, and you are supposing not an exam going right now, and I would suggest you in that ways, please go and watch my regular videos of Gurukul. It is around 60 hours. You can easily watch and you can learn in a more better and a more deeper way in that part. Okay, but anyhow, all of you guys, कोई और दिक्कत है, please let me know, or can I move to the next chapter of neoplasia? So give me a thumbs up if all of you are just listening to me. One thumbs up if you're all listening to me, guys. We move to the next chapter of neoplasia. Okay, neoplasia. The first gene I'll discuss here is a tumor suppressor genes. Okay, tumor suppressor gene is caused by the p53 gene, and the p53 gene is called as guardian of genome. It's a molecular policeman of cell cycle. oncogenic stress, oncogenic stress and hypoxia causing cell injury are the two main reasons what activates the guardian of genome. Okay, guardian of genome. So this one and this one, they both activate P53. P53 activates P21. P21 inhibits G1S more than G2M. Okay, they check for mutation. Once the cell cycle stops there, it checks for mutation. If there is a mutation, they would repair it. If repair is possible, they'll go back to cell cycle. If repair is not possible, will cause apoptosis by causing activation of back and backs. Remember, back and backs, padha tha na pehle, they are the pro-apoptotic causing gene, and GAD45 is a repair causing gene. Okay, we then move to the RB gene. Okay, RB gene. So RB gene is chromosome number 13q, governor of proliferation. Governor of proliferation. We then move to the growth factors, which is how does it cause? Dekho, if there's any growth factor, it will activate the growth factor receptor. The moment it acts on this, it activates cyclin D and CDK4. Of the what happens normally, this is very important. Normally, the RB gene is in a state of hypophosphorylation where it does not allow any cell proliferation, and because it does not allow any proliferation, is called as an active form of RB. Active form of RB. When the K kinase acts on it, the RB will become phosphorylated, E2F becomes free, and because of which it activates the G1S more than G2M. The tumors caused by the RB mutation is bilateral retinoblastoma, osteosarcoma, and the pineoblastomas. This whole combination of a patient having bilateral retinoblastoma with a pineoblastoma is called as trilateral retinoblastomas. Trilateral retinoblastomas. Now, about the mutation of P53, P53 being a policeman of a cell cycle, it's a policeman of a cell cycle, they often lead to germ line mutations. Okay, and they lead to what is referred to as a tumor called as blast. How to remember? P53 क्या है? Policeman है. It is no policeman, they can be blast. And what are the blast tumors? The blast tumors actually are the blast tumors, sorry. The blast tumors, they actually are breast, brain, lung, adrenal, skin, stomach tumors. Okay, breast, brain, lung, adrenal, skin, stomach tumor are the blast framing tumors. Okay, this is a very frequently asked question. It is about the immunohistochemistry. Different type of IHC you must remember. For example, for cytokeratin, the IHC is carcinoma. Okay, carcinoma. For a vimentin, it is sarcoma. For desmin, it is rhabdomyosarcoma. For a melanoma, it is HMB45. Okay. For a LCH was also asked in last year's NEET PG exam actually, but can be asked in FMG also, is S100. And for neuroendocrine tumors like small cell cancer, pheochromocytoma, or a carcinoid, it is synaptophysin, chromogranin, neuron specific enolase, and CD56 are the main IHCs that you must remember. Out of them, I can tell you, this is a very frequently asked question, the first one. The main IHC for cytokeratin is carcinoma, is actually carcinomas. Okay? Chalo. We now move to the next part where you see the normal peripheral smear. Okay, normal peripheral smear. A normal peripheral smear, it is basically the, you can just identify the first cells here. Dekho. These all are the RBCs. The small one has a platelet. This is a mature segment in neutrophils. This is a bilobed neutrophil. This is a basophil, lymphocyte. Kidney shaped cell is a monocyte, and this is a immature neutrophil called as band forms. Okay, band forms. Let's now see the CD markers here. Dekho. In CD markers, any cell who has a marker of 34, 34 is a marker for immaturity. So blast being CD34 positive, they are often having a 30, blasts are often immature, and so they have 34 positive. The moment the cells become mature cells, it becomes 34 negative and 45 positive. 34 negative, 45 positive. ठीक है? All myeloid, M for myeloid, M for MPO. याद रहेगा? M से myeloid, M से MPO. Some other markers, if you can remember, it's well and good. It is 13, 33 and 117. Lymphoid में B में 19 होता है. If you can remember 19, you cannot forget others. Like 19 के बाद 20, 21, 22, 23, 24. Other markers are 10, 79A and PAX5. T cell is CD3, 1, 2, 3, 4, 5, 6, 7, 8. So all the marker from 1 to 8 is T cell marker. NK cell is 16 and 56. Just remember NK में क्या क्या है? 6 है and 6 है. Okay. Mono is a four-letter word है, and both the markers are 4 at last. तो 6 and 6 वाला NK, 4 and 4 वाला is mono. ठीक है? CD marker. Right. So say with all of you say with me. Marker for immaturity 34. Maturity 34 negative, 45 positive. M से myeloid, M से MPO. B 19, T 3, NK 16, 56, mono 4, 14, 64. Okay, and ultimately the basic marker you must remember. Okay, chalo. Next we move to the main classification system you should know for AML. This is for acute myeloid leukemia, AML. So AML is a WHO 2023 classification in which AML with defining genetic abnormalities are seen. Actually, AML has mutations of PML RARA of 1517 type, RUNX T1 of 821 type. CBFB MYH is translocation 1616, also called as inversion of chromosome number 16. Very rarely, this is a very rare one, but can be seen. It is a BCR ABL translocation 922. However, the main thing we must remember is the first one. How to remember this? Look 16 say. What is half of 16? 8. Right? And what is comes before 16? 15. What comes after 16? 17. Then 16 with 16. This one is 8 with 21. It is 16 with 16. So if you can remember the number 16, it will help remember all the mutation of acute myeloid leukemia. From 16 you must remember. Okay. 15, 17. 16 का half कितना हुआ? 8. So 8, 21 and 16 with 16. And also remember 9 with 22 also is a mutation there. Now, what is important about these three tumors is all of them actually are AML irrespective of blast percentage. Normally, we must get how much percent blast? 20% blast. But for these mutations, even if we get a 5% blast, it is acute myeloid leukemia irrespective of the blast percentage. Chalo. Next is about the FAB classification of AML. So basically, how to classify the FAB classification? It is something like initially the cells will mature and then they will differentiate. So what happens? M0 is a AML without any differentiation, no differentiation. M1 is with differentiation. M2 is go down with maturation. Okay? Then M3 is promyelocytic leukemia. Promyelocytic leukemia, okay, is APML. Now M4 is myelocyte also, myeloblast also, monoblast also, myelomonoblast leukemia. M5 is monoblastic leukemia. M6 is erythroblastic leukemia. M7 is erythroblastic leukemia. Among them, because it is having a mature, it's a best prognosis, and without differentiation is a poorest prognosis. With maturation में it's a chloroma. With maturation it's a chloroma. Promyelocytic leukemia में maximum or rod which is DIC. Maximum or rod which is a DIC. Okay, maximum or rod and hence can lead to DIC. Now remember, acute M7 megakaryoblast leukemia often shows a Down syndrome, but such Down syndrome are having a transient Down syndrome. Sorry, transient leukemia, not transient Down syndrome. Sorry, Down syndrome patient have a transient AML, and therefore they have a good prognosis. Among this, because these are the four which shows myeloblast, these four can only show you ORRs, and I told you among them the max ORR is seen in M3. Max are already seen in M3. Okay. Let's now see the chronic myeloid leukemias. In the chronic myeloid leukemia, the first topic is the PH chromosome. And PH chromosome, guys, is a translocation 9 long arm with 22nd long arm, also called as BCR ABL translocation. Okay, what happens is when the BCR ABL comes together, they activate tyrosine kinase receptors, which ultimately causes CML. Drug to inhibit tyrosine kinase is called as imatinib. Some other drugs are imatinib, dasatinib, ponatinib, bosutinib, and nilotinib. Just remember, tyrosine kinase inhibitors are tinibs, imatinib, dasatinib, ponatinib, bosutinib, and nilotinibs. Okay, what happens in CML because of the huge amount of myeloid, and which myeloid? Mature myeloproliferation, they show a garden party appearance, which includes myeloid cells like neutro, bands, metamyelo, myelo, promyelo, and blasts. Apart from the myeloid series, myeloid neutrophil series, they also have basophilia and eosinophilia. However, if the question is what is a prominent cell seen in a chronic myeloid leukemia, your answer should be neutrophils. Okay, neutrophils. Because basophil number is very less, 1%, 2%, maybe 5%. But neutrophil, 70%, 60%, like this. And so maximum in cell number is in neutrophils. Okay. And they show basophilia along with eosinophilias. Now, let's now come to the non-Hodgkin's lymphoma. How to remember non-Hodgkin lymphoma? First of all, remember that CLL or SLL, this shows a pseudo follicular pattern, and on the peripheral smear, they show convent girl appearance, and smudge cells. All the images I've already discussed with you yesterday. Every image is important. I've discussed with you separately yesterday, and therefore today I'm not discussing images. I'm all discussing the main pointers today. I'm not discussing the images today. Okay. Mantle cell lymphoma is single L. Single L है तो mantle cell lymphoma is a BCL1. So 1 is on chromosome number 11, and all lymphoma often translocates with chromosome 14. So because mantle में single L है तो BCL1 on chromosome number 11, so 1 and 111, it's with translocation with chromosome number 14. In follicular lymphoma double L है तो BCL2 हो गया, and BCL2 is on 18. So what is the translocation? 14, 18. Diffuse large B cell lymphoma has BCL6, which is on chromosome number 3, and so क्या हो जाएगा? 3, 14. So याद रखना 11, 14, 14, 18, 3, 14. 14 रहना है. Burkitt. In Burkitt, remember B. B, after B comes C. CMYC. And because B looks like number 8, it is 8, 14, 2, 8, and 8, 22. Next, there is a marginal zone lymphoma, which shows BCL10 positivity, and hairy cell leukemia, which often shows a BRAF positivity. Remember, the hairy cell leukemia, they often shows a fried egg appearance. Fried egg appearance. This is very, very important. Whereas starry sky appearance, it is seen in a case of Burkitt lymphoma. Fried egg appearance seen in a case of hairy cell leukemia. They show TRAP positivity, annexin A1 positivity, and DBA44 positivity. So I expect questions from this is like the Burkitt lymphoma shows starry sky appearance, and fried egg appearance is seen in hairy cell leukemias. Just remember about the Hodgkin lymphoma, what you should know about the Hodgkin's lymphoma. First of all, that they don't involve often the Walder ring and the mesenteric lymph nodes. They often involve the axial lymph nodes, first of all. Secondly, they, as you all remember, they have a binucleate owl eye appearing cell. ऐसा. 2 nucleus. Owl eye appearing cell. Such cells are referred to as reed. Okay, such cells are referred to as reed. Sternberg cells. Can any of you tell me what is the CD marker for Hodgkin lymphoma with CD marker? Can you tell me what CD marker should come positive in Hodgkin lymphoma? Whereas I write the classification here, which can be a case of classical Hodgkin lymphoma and can be a case of non-classical Hodgkin lymphoma. For a classical Hodgkin lymphoma, remember it is mixed cellularity, nodular sclerosis, lymphocyte rich, and lymphocyte depleted. For non-classical, it is NL, PHL. Okay, NLPHL. M is mononuclear cell. This one is lacunar cell, lacunar, lacunar cell, and this one is a popcorn cell, popcorn cell. Okay, also called as LNH, means lymphocytic and histiocytic variety. What is the CD marker for Hodgkin lymphoma? Answer is CD15 and 30. In Hodgkin, the marker is 15 and 30. 5 and 23 is a marker for, for CLL. 5 and 23 is a marker for CLL. For Hodgkin lymphoma, it is 15 and 30 positive. Among all the variety, most common in India is mixed variety. Most common worldwide is nodular sclerosis. Next, we move to the RBC anemia. Let's first differentiate intravascular and extravascular hemolysis. Okay, whenever a RBC has got destroyed in the vessels, we call this intravascular. What comes out from the RBC is what? What should come out is hemoglobin, and as we use the word hemoglobinuria, we use the word hemoglobinemia. Sorry, hemoglobinemia will then combine with haptoglobin, and hence it is decreased haptoglobin levels, which is normal in a case of extravascular because there is no hemoglobinemia there. अब देखो क्या हो रहा है. Suppose the RBCs have got destroyed in the vessels. So what comes out from the RBC is hemoglobin, and hence is hemoglobinemia. In the extra, it is destroying in spleen. There cannot be hemoglobinemia, and so hapto levels remain normal. Now, you come back to this one. It is decrease in the hapto levels. It is normal in this case. Hemoglobinuria here is normal here. Hemosideриnuria here, it is again not seen here. LDH is raised here, LDH is increased here. Why is LDH increased in both of them? Because LDH is an enzyme. An enzyme can diffuse out in the blood in case of intravascular, and from the spleen what can happen, LDH can leak out into blood vessels. If LDH leaks out into vessels, it is called as extravascular hemolysis. There is no spleen enlargement in the intravascular, while there is spleen enlargement in the extravascular hemolysis. Increase in the bilirubin levels, it can occur in the extravascular hemolysis. Okay, so if you get a case, if you get a case of a hemoglobinemia, hemoglobinuria, low hapto levels, high LDH levels without splenomegaly, it's intravascular hemolysis. In extravascular क्या होगा? There is jaundice and splenomegaly only. ध्यान रखना. If you get these two findings, it is extravascular hemolysis. ठीक है? Now see the examples. In intravascular hemolysis, it is PNH. How to remember? When someone is saying you example of intravascular, you must appreciate he's asking you hemoglobinuria. So which disease will show you hemoglobinuria? PNH, PCH. Immune cause can lead to both extra. About the extra examples, the best way to remember is think of an RBC and go from outside to inside. What is outside? Membrane. You go inside, what you get? Enzyme. And you see what? Hemoglobin. The defect of RBC like HS, HE, enzyme में G6PD deficiency, pyruvate kinase deficiency, and hemoglobin में thalassemia, sickle cell anemia. Immune cause, I tell you IHA can be both extra also, intra also. Among them, I'll discuss the first of all, HS. HS is an autosomal dominant trait in which the defect lies mainly in the iron chirin, more common than band 3, more common than spectrin. Because of the loss of RBC membrane, surface area decreases. When surface area decreases, a normal appearing biconcave RBC will now become a spherical RBC. Maximum hemolysis. Remember, even though in HS, the most common defect is what? Ankyrin. Remember, maximum hemolysis is seen in alpha spectrin deficiency. Okay, maximum defect, or you can say most common defect in HE is also spectrin loss. So what is the question asked? Most common defect in HS, ankyrin. Most common defect in HE, spectrin. Maximum hemolysis in HS occurs in spectrin deficiency. Clear हुआ? Okay. Next is G6PD deficiency. Disease is not autosomal dominant. Disease is X-linked recessive more than a autosomal recessive disease. यहाँ पर because of the deficiency of glucose 6-phosphate dehydrogenase, the amount of NADPH would decrease. क्यों? Because this enzyme, it converts glucose 6-phosphate to 6-phosphogluconolactone, which converts NADP to NADPH. Okay, if this is not there, this is not there. If NADPH is not there, the amount of GSH, the reduced form of glutathione, is low. If reduced form is low, H2O is not reduced and keeps on increasing. In the peripheral smear, the patients often present bite cells, blister RBCs, and the Heinz bodies. Okay. Then remember, in GXPD, the maximum hemolysis occurs due to what? Episodic causes. And episodic includes infections, fava beans, and a very important drugs, guys. Primaquine. I expect this question every year, and it has not ever failed me. Primaquine, GXP deficiency. Primaquine hai, quinine hai, sulfadoxine, fluoroquinolones, dapsone, vitamin K, they all can lead to GXPD, but one most important drug is a primaquine deficiencies. Okay, to remember, bite, blister, and Heinz bodies are a finding of GXP deficiency. Next is sickle cell anemia. In the disease, there is an autosomal recessive disease where, as you all remember, beta chain by 6 position pe glutamic acid is replaced with valine. Because of the change in charge, there's change in charge, change in solubility, and change in structure. How does it change? Normally, a hemoglobin is soluble form. If this is a hemoglobin, RBC, inside this you'll see a soluble hemoglobin like this. Okay, but once there becomes a SS, SA, will now change from a soluble hemoglobin to a insoluble precipitation, which can damage membranes here. Because of the damaged membranes here, what can happen? They'll all stick to each other. When they stick to each other, blood flowing from this area would decrease, causing ischemic episodes. Ischemia can lead to pain. Is it reversible? Yes. Was also asked in last year's FMGE exam. What happens is the most common defect is a hand-foot syndrome. And the second most common problem is infections which can occur in bones, causing osteomyelitis. And osteomyelitis is caused by Salmonella typhi, but can also lead to chest infection called as acute chest syndrome. The main treatment is oxygenation, IV fluids, but it also can give hydroxyurea, because hydroxyurea increases HbF, and high amount of HbF will decrease the sickling episode in these patients. Next, we move to the main table of iron deficiency anemias. In iron deficiency anemia, what will happen is serum iron, ferritin, transferrin saturation, and total iron binding capacities. Dekho, when you get a case of this, you should also always know that ferritin and TIBC are always inversely proportional. Just remember this thing. TIBC and ferritin are inversely proportional. Now see, if a patient has iron deficiency anemia, what should happen is ferritin should be low. Obviously, now, if a patient has iron deficiency, the amount of serum and ferritin should be low. If iron is less, transferrin can't bind to anything, and so transferrin saturation also becomes low. The moment you see a low ferritin, I told you TIBC is opposite, it goes high. What happens in iron overloading condition, that sideroblastic anemia, is everything is exactly opposite of IDA. What we saw here, decrease, 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 and increase. यहाँ पर increase, 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 and decrease. So sideroblastic anemia is exactly opposite to iron deficiency anemia. What happens in ACD? ध्यान रखना. Why did we discuss this table together? Is because ACD and IDA, they both have low iron, they both have low saturation. But what is the main difference in ACD is this one, high ferritin. The moment you remember high ferritin in ACD, TIBC decreases. So one single thing that I want all of you to remember is in ACD, ferritin level is very high. Because of high ferritin, TIBC is very low in these cases. Clear? Now, next is megaloblastic anemia. Okay. In megaloblastic anemia, also referred to as macrocytic anemia. Macrocytic anemia. What happens? The most common cause of macrocyte is a non-megaloblastic anemia, which occurs due to alcoholism. This is overall the most common cause, you can say, along with hypothyroidism. In the megaloblastic anemia, the bone marrow shows large blasts. Okay, the bone marrow, it shows large blasts, which causes defective nuclear maturation with B12 and a folic acid deficiencies. B12 and a folic acid deficiencies. If we talk about the megaloblasts, the megaloblast में क्या होता है? The blasts are large in size and the nucleus is immature. We call sieve-like chromatin. We call them sieve-like chromatin. ठीक है? In the peripheral smear shows macrocytes, macrovalocytes. It shows Cabot rings, Howard jelly bodies, teardrop RBCs. What they can ask you is, Cabot rings and Howard jelly body are also seen. Answer is severe hemolysis, like thalassemia, plus after removal spleen, post-splenectomy. Teardrop RBC is seen in, answer is myelofibrosis. Myelofibrosis, also seen in myelofibrosis. Okay, just remember a few things. That we talk about a B12 and a folic acid deficiency. The B12 source is non-veg food, and B12 absorption occurs mainly in the ileum. Along with that, stomach and duodenum is also important. The folic acid absorption mainly has a vegetarian food, and the green leaf vegetables are mainly having folic acid. So folic acid absorption mainly occurs in jejunum. So B12 absorption, stomach, ileum, and duodenum. Folic acid in jejunum. This is what you must also remember in this case. We now move to the next chapter of vessels. So any doubts till now? Let's take a small session. Any doubts till now, or you want to ask me any questions? I can explain you that topic also. Batao. Or if you say that it's okay, then I can just move ahead without wasting any further time. We can surely move ahead. Guys, any doubts till now? All of you who are watching till now, I can just see around 60 students live watching right now. So in case you have any doubts till now, please let me know. I'm waiting for your reply. Guys, any doubts, please tell me no. No, if not, you can let me know that too. I can just move ahead that way also. So can I move ahead, all of you? Today's PYQ session for NEET PG. This is a FMG class though, but for NEET PG, I believe today there is no class as such. Tomorrow, Dr. Ashwini will take the class of PYQs. Okay. बोलो आगे बढ़े. I'm assuming that I can move ahead. I can't see any message though. Chalo, let's move ahead. In vessels, what does it mean? It means inflammation of vessels, and what they often ask you is that there is a large medium, and small vessel vasculitis. In large, it is GNT, giant cell and Takayasu. In medium, it is PNK, Pan and Kawasaki. In small, it is with immune complex with Posse immune vasculitis. Okay, Posse immune vasculitis. Number one. देखो, in the large vessel vasculitis, how to remember? It is GT. Last test we give GT. So large vessel vasculitis is G से giant cell arteritis and T से Takayasu arteritis. Then medium vessel में PK, P से Pan and Kawasaki. Small is immune complex without immune complex. With immune complex is Henoch, Schollin, Purpura and SLE. With Posse immune are those diseases which have ANCA. And which disease have ANCA? Church-Strauss, Wegener's and microscopic polyangiitis. The three diseases, they have actually ANCA inside them. What they ask you, number one, is a Kawasaki disease. Kawasaki atakna, in this hot summer, when you drive a Kawasaki bike, apply cream on the face. When you drive a Kawasaki bike, apply cream on the face. C, conjunctivitis, rash, and polymorphic rash. E is edema. A is adenopathy. M is mucosal inflammation of tongue called as strawberry tongue. Okay, conjunctivitis, rash, edema, adenopathy, and mucosal inflammation of tongue called as strawberry tongue. It is very frequently asked, what is the main treatment for Kawasaki? The main treatment for Kawasaki, it is that it is having a IVIG with high dose aspirin. Reason is, if you don't treat the patients of Kawasaki, it will lead to myocardial infarction and coronary artery aneurysms. Secondly, they ask you questions on the Henoch Schollin purpura. It is a most common vasculitis. Okay, most common vasculitis in children. It's a type 3 hypersensitivity reactions. Now, what happens clinically? The whole problem presents 1 to 2 days after a viral fever. It causes a circulating immune complexes deposition in the kidney called as glomerulonephritis, in joints called as polyarthritis, in mesenteric vessels called as colic pain abdomen, and on the skin called as palpable purpura. Multiple times asked question, I can tell you, multiple times asked question, do they show thrombocytopenia or thrombocytosis? Just remember, they show thrombocytosis, not thrombocytopenia. Okay, they show thrombocytosis. Diagnosis may, we can take a purpuric biopsy. It shows neutrophils in the capillaries called as leukocytoclastic vasculitis, also not a very important finding. The hallmark finding is the IgA deposition in vasculitis. Okay, IgA deposition in vasculitis. Okay, IgA deposition in vasculitis. ठीक है ना, क्लियर हुआ? चलो, now we move to vegetations. Basically, देखो, what is a vegetation? Any growth on the cardiac valve. Okay, any growth which is a cardiac valve. It is rheumatic heart disease, non-bacterial thrombotic endocarditis, Libman-Sack endocarditis, and infective endocarditis. Okay? The rheumatic heart disease, NBT, Libman-Sack endocarditis, and infective endocarditis. There are 4 types of them. देखो, NBT is also called as marantic. This was asked question in FMG question 2 years back. They asked you marantic is which one? NBT. Very frequently they ask you etiology first of all of this one. Group A, beta hemolytic streptococcus 1, 3, 5 and 18. In this case, it is hypercoagulable states. Cancers and malnutritions are the main causes. Remember that Libman-Sack is in SLE and infective endocarditis. It is often caused by Staphylococcus aureus. Okay. Now, all of them involve mitral valve. Even though infective endocarditis, it involves mitral and aortic. Just remember, it is mitral more than aortic. Sorry, ulta arrow ban gaya. It's mitral more than aortic. Along the lines of closures, are true for both the first and second one. If it is the Liebman sac, it is on the valve and also below the valve. On the valve and below the valve. Okay? Then it is on the valve cusp for infective endocarditis. If size of the vegetations are small hai, warty hai, it is rheumatic heart disease. Medium size, no inflammation, and loosely attached. Why? Because actually you remember that NBT is a vegetations which come from the DVT, from the legs, and from that it comes to the heart. This type of change from a leg to the heart is what is referred to as a NBT, Marantic wala. If something is coming from the legs to the heart, it can't be attached very strongly and hence is loosely attached and also has no site of inflammation. Okay? Verrucous कौन सा है? Liebman sac, and large, fiber and bulky is the infective endocarditis. Among these three, the only one with destructive, only one for destructive, it is the last one, that is a infective endocarditis. One question is, I'll tell you here, even though I told you that mitral valve is the most common valve involved, right-sided tricuspid valve is the most common valve involved in the intravenous drug abusers. In the intravenous drug abusers. Chalo. Next topic is among them rheumatic heart disease, and the first thing we'll discuss here is a pancreatitis. Yes, at any point of time, if you have any doubts anywhere, ekdam bindas okay, you can ask me. Okay, don't feel a bit shy. You can ask me any doubts of any topic that you have a doubt into. Just ask me. I'll surely answer you. Not exactly that time. Whenever once I finish a topic, I'll take that doubt there. Sir, because of you, I understood pathology. I learned from TND class and I have faith. Thanks a lot, very much. Thank you very much, dear. For NEET PG useful? Surely yes. But NEET PG may be actually the same thing are asked, right? It is just that in FMG, the questions are basically the choices become more easier, but the questions are almost same only. If you look at the January FMG question paper, is almost like a NEET pattern only. So I won't say the different there. Just the main difference I would say is that it is the choices will become more easier in the FMG, and more importantly, no negative marks. That's why is everything same there. Okay. Is it important for NEET PG also? Yes, that's what I'm telling you. NEET PG means everything same only. What I've told you for the last around 1 and 15 hour and 15 minutes is all the same. But all of you, while you're watching this video, please ensure you just have this PDF alongside with you, and the PDF is already uploaded in my Telegram groups. Okay. Rheumatic heart disease. It shows pancreatitis, which means all three layers are involved. In the pericardium, it is bread and butter, pericarditis. In the myocardium, it's Asher body. Asher body has all three layers involved: pericardium, myocardium, and endocardium. Endocardium में it shows vegetations. Vegetations are along the lines of closure, acid. They're along the lines of closure, which are left atrial wall, and they have a thick patch. The thick patch often is called as McCullum's patch. So what all they have asked you is bread and butter pericarditis, Asher body with its typical annexure cells, vegetations which have a left atrial thick wall, a thick patch, sorry, it's McCullum's patch. In prophylaxis, it shows primary and secondary prophylaxis, which is a benzathine penicillin. In chronic rheumatic arthritis, what happens? The valve will often have a small opening, and a small opening is called as fish mouth appearance. The valve leaflet becomes fibrous and closed. It is called as fish mouth appearance. Treatment is benzathine penicillin. About the infective endocarditis, remember the two types of infective endocarditis. One is acute and one is subacute. In the acute is virulent form. Subacute is a virulent form. What they have asked you, if the infection occurs in early phase, it is often a skin commensal, which is Cons infection. If it is occurring beyond suppose 1 year, it is often due to Streptococcus viridans, and hence it is non-virulent etiologies. Often the valve involved in acute is a native or natural valve. The valve involved in subacute is a damaged or prosthetic heart valves. What happens is, suppose the valve head and there's a large vegetation on the valve cusp, which is friable heads, bit bulky, this vegetation can break. So once they break, they can lead to embolization at different episodes, different areas. They can lead to embolization at different areas and can lead to some phenomenon which are vascular and some phenomenon which is vasculitic or immunological phenomenon. If suppose something is a vasculitic phenomenon, the example of this phenomenon is glomerulonephritis. इसका example क्या है? Glomerulonephritis. It can be arthritis and is often Osler's nodes. Osler's nodes. Osler's nodes are the painful lesions on the fingers. About the vascular lesions, these often include what? Yes, they include the Roth spots. Roth spots is on retina, and they use the JNV lesions. Along with this, all the ischemia, infarcts, they also are the vascular phenomenon. याद हो जाएगा? अच्छा. Now, criteria for diagnosis. Criteria for diagnosis in case of a rheumatic fever is a Jones criteria, which says one major plus two minor or two major. For infective endocarditis, it's a modified Duke's criteria. Modified Duke's criteria. For modified Duke's criteria, it is two major, okay, two major, one major with three minor, or all five minor. Or all five minor. These all are what you must remember. Last in January FMG, they asked you how many minor criteria are required for infective endocarditis. So कितना होना चाहिए बताओ? 5. But 5 was not in the option. Answer was 3. Yes, 3 minor. Okay, because 5 was not in the options. Chalo, let's move to lungs now. Guys, just share the video again to your friends who just want to go very strong in searching pathology. They can just watch the video with us. So if you can just ask them to watch this video, would be very helpful for them as well. Okay. Chalo, moving ahead to the ARDS. First is the sepsis. In sepsis, it is the first etiology of ARDS is sepsis, pulmonary infections, head trauma, and aspiration. Some others not very important. They are just written here, not very important though. These four are the most important here. What happens in ARDS? Any etiology would first stimulate the macrophage of the alveoli, which will then activate IL-1, 8, TNF-alpha, and 6. All cytokines would activate what? Neutrophils. Neutrophil will damage what? Endothelium. Because of this, neutrophils will enter the alveoli and release what? Protease. Protease would damage the type 1 epithelial cells, and type 1 cells help in what? Oxygen exchange. Because the oxygen exchange will decrease, it will lead to ARDS, acute respiratory distress syndrome. ARDS. ठीक है? अच्छा. Then what happens? Because of the extensive damage of the endothelium, fibrin leaks out, and fibrin would now deposit in this part. The whole deposited fibrin in this part is staining pink on H&E staining, and hence it is called as hyaline. So hyaline membrane disease is the other name for ARDS. You should not confuse ARDS to RDS. Respiratory distress syndrome occurs due to type 2 deficiency in a surfactant deficiency in a neonate. This is a ARDS. It happens due to endothelial damage and type 1 pneumocystic damage. Among them, the most important cell damage is the endothelial cell damage in a case of ARDS. Okay? Chalo. The three stages. First stage is stage of exudation. What is exudating out? Fibrin hai, proteins hai, inflammation hai, everything is coming out. Second stage mein, the type 2 cell which was intact would now proliferate, is proliferation of type 2 cells, and finally there is fibrotic stage. Next is chronic pulmonary disease, obstructive and restrictive pattern. Obstructive and restrictive pattern. In the obstructive pattern, It is emphysema, asthma, chronic bronchitis, and bronchitis. In the emphysema, it's acinus. In these three, they all involve bronchus. Do you remember? The combination of emphysema and bronchitis is referred to as COPD. How we differentiate these two? By looking at the FEV1 and FVC. Obstructive may both decrease, but FE1 decreases much more than FVC. So ratio is less than 0.7. In this one, both decrease equally. Ratio is more than 0.7. That's the best way to differentiate between obstructive and a restrictive pattern. Chalo. Let's first start with the emphysema, who are called as pink puffers, and the main problem occurs in damage to acinus. Acinus is a part of the airway distal to the terminal bronchioles, which are respiratory bronchiole duct and the sac. Now they go. When you say the emphysema is there, it can be damaged to the central part, matlab this part, where there is a respiratory bronchiole, ये वाला part, or it can be respiratory bronchiole, duct and sac, all these three. All the three together is called as pan-acinal emphysema. The main etiology for central acinal is something which is in the proximal part. So smoking often reaches the proximal part of acinus. Smoking is the most common cause of, yes, smoking is the most common cause of proximal acini, which is a central acinal emphysema. Pan-acetylcysteine alpha-1 antitrypsin deficiency. Now, how to remember the lung involvement? Smoke goes up. The smoking involves apex of lung. याद हो गया ना? And base involves in the alpha-1 antitrypsin deficiencies. Okay, this is how the dilated and destroyed airways look like. Dilated and destroyed airway look like, and this is a thinned out septum. Thinned out septum. In the normal lung, this is a normal lung here. The cut opens up the ribs here. This is the emphysematous lung. Look at the huge dilatation of the lung here. It is called as emphysematous lung. Barrel-shaped chest. Barrel-shaped lung is the name there. In the remodeling of the lungs, what happens? Normally, this is the lumen. ये lumen है. ठीक है? What happens in asthmatic lung is the lung will decrease in size, the lumen decrease in size because wall will increase in size. The wall will increase and lumen will decrease. That's what happens in the asthmatic condition. Very important to remember, in asthma, you get 3C. The 3C in asthma, the first C is Charcot Leonid crystal. These are eosinophil crushing artifacts. It can show you Crayola bodies, second C, which are the damaged respiratory cells, often can be seen bronchial washings, the damaged respiratory cells. And they can show you Kirschmann spirals with spiral arrangement of the impacted mucin plugs. Mucin plugs are called as Kirschmann spirals. Okay, Kirschmann spirals. Second is a chronic bronchitis. Chronic bronchitis. Okay, what happens here is, by definition, more than 3 months of productive cough in the last 2 consecutive years, where the main etiology is a chronic irritation. Example, smoking. The smoking will lead to huge amount of the submucosal glands. Because of the huge amount of glands, what happens? It leads to increase in the reed index. Reed index is a ratio of the mucin gland layer versus a bronchial wall layer thickness. The ratio normally is less than 0.4, but if the ratio is more than equal to 0.4, it is highly suggestive of chronic bronchitis. Because of the irritation, the chronic epithelial cells like this, they will change to a cell like this. And what are these cells? Yes, these are flattened cells, and they're called as flattened cells are called as squamous epithelial cells. That means from the column epithelium, they lead to what is called as squamous metaplasia. And because of squamous metaplasia, they often lead to squamous cell carcinoma. Squamous cell carcinoma. I will explain to you about the asthma. That's done. Now, coming to bronchiectasis, a very, very important question for all of you guys. Very important. Dekho. Chronic necrotizing destruction of elastic and smooth muscle of bronchus by infections. The main word I want all of you to focus on here is infections and bronchus getting destroyed. Two things. Why it happens? Because of infections. Example, foreign body, staph, strepto, Klebsiella, Pseudomonas, autoimmune disease, and among the congenital causes, it can be very importantly Cartagena syndrome, which is bronchiectasis, sinusitis, cytosinusitis, BSS, BSNS. Along with that, the patient often show decreased motility of the sperm called as asthenozoospermia. It often leads to a primary ciliary dyskinesia, primary ciliary dyskinesia, and that is due to absence of dynein arms. This absent dynein was a image-based question in last January FMG. Okay, it's due to absent dynein. In Young syndrome, the first two findings are same. That's a bronchiectasis and sinusitis. But the third finding is the azoospermia. The CFTR mutation is seen in cystic fibrosis. It often shows false when it's put up. Next is a restrictive lung disease, and the main disease we'll discuss here is pneumoconiosis. Okay, pneumoconiosis. In pneumoconiosis, it is due to chronic fibrosing lung disease due to inhalation of organic, inorganic dust, fumes, and vapors. All of them they show Kaplan syndrome, and Kaplan syndrome is RA with pneumoconiosis. RA with pneumoconiosis. Among these three, the most common is silicosis. Okay, first thing. Lungs, upper lobe, the only asbestos involves lower lobe. Kaplan syndrome in all these three are seen. Remember, risk of TB, if it is asked, it is seen mainly in silicosis. Lung cancer seen mainly in asbestos more than silicosis, and that too, they have more commonly adenocarcinoma of the lungs. In the macrophage basically, they have a coal deposition, which is form of a coal macule and a coal nodules. Silica nodules, they become collagenous nodules in the silica. In the asbestosis, they show asbestos body, and they also show the ferruginous body. Only disease among all the three which can involve pleura is called as asbestosis. It can lead to pleural plaques, effusions, and can also lead to lung fibrosis. Among these three, what is the MCQ asked? Kaplan syndrome. All the three. But the first seen in co-worker. Fibrosis, all three. TB, silicosis, lower lobe, asbestosis, lung tumor, asbestosis, asbestos body and furnace body, asbestosis. And the anthracotic means black pigmented lung is a finding of coal worker pneumoconiosis. Bus. Okay? Next is the finding. This is a coal worker. Look at the black pigmentation. Look at the black pigmentation, coal worker pneumoconiosis. This is a typical sheikh kebab appearance. The sheikh kebab appearance is a finding of asbestos body. Okay, asbestos body. In the lung tumor, it is smoking, radiation exposure, asbestos, and silicosis. Squamous cell cancer, mutation wise, P53 and P63 with a IHC of cytokeratin. Remember, the most common lung cancer in smoker is squamous cell cancer. Most common lung cancer in India now has changed to adenocarcinoma, more common than squamous cell carcinoma. Site में it is bronchus, which mostly central in location, and often the microscopy finding shows keratin pulse and malignant variety of squamous cells. The same thing in adenocarcinoma in the lungs, they basically have the mutation of EGFR1. It's having good prognosis. Remember this thing is the most common variety in the world. India, females, young age, non-smoker. सब में most common क्या है? Adenocarcinoma. Site is mostly in the peripheral location. It is acinus in location. In microscopy, they show glands, and the gland is filled with mucin. Glands is filled with mucin. Okay? Now, one variety is called as, this is the third variety I can say, it's a pre-malignant variety. It's a bronchoalveolar variety of lung cancer, also called as adenocarcinoma C2. Since there is no innovation among all the lung cancer, this has a best prognosis. Okay? The fourth tumor here is a small cell cancer. The fourth tumor here is a small cell cancer. Among all lung tumor, worst prognosis. See, most common lung cancer in smoker is squamous cell cancer. But every case of small cell cancer occurs in smoker. Doesn't mean the most common lung cancer in smoker is small cell. It is squamous cell carcinoma. Mostly all the para neoplastic syndrome of the lungs are seen with small cell cancer except hypercalcemia, which is feature of squamous cell carcinomas. Okay. They often show spindle effect because the cells often they are spindle in shape, they break, and what comes out is a chromatin. Chromatin often enters vessels, and vessel from inside stains the blue. It is referred as Azo-Pardy effect. I would just tell you to remember two things mainly. Number one, keratin pearls, ये वाला pink area. Keratin pearls is a feature of squamous cell cancer. Glands with mucin. Glands with mucin is a feature of adenocarcinoma. Glands with mucin is the finding of adenocarcinoma. इतना याद रख लो. All question done, solved है. पक्का पक्का. बोलो, any doubts now? चलो. Moving to the liver, the first thing is a chronic venous condition of liver. This was also asked in Jan FMG. This often shows what is called as nutmeg liver. Acute may it shows hydrotropic change in central local area. This is never asked. What they often ask you this question, nutmeg liver. Nutmeg liver में all the red color areas, red areas. Take a red area. It's due to necrosis and vessel dilatation. So sinusoid dilatation and necrosis shows red areas, and the pale or the white areas are the fibrotic areas. Red areas are necrotic areas and vessel dilatation. Pale areas are fibrotic areas. It is called as nutmeg liver. ये पूरा red area है. This whole area is central vein, and all the area around central vein is red. Polytriad, all the area on polytriad is white. This alteration of nutmeg liver is red and white color. Alcoholic liver disease. In this, the alcohol consumption is important, where around 60 to 80 grams of alcohol per day often leads to alcoholic hepatitis, and the main risk factors are HBV, HCV, HIV, and females are often involved more than the males. Females are involved often more than the males. In pathology, what happens? Alcohol often converts to acetaldehyde and ultimately will change to the toxic to the liver. What happens? This will cut deposition in the fat, and hence the fat deposition starts occurring because of alcohol intake. Because of fat deposition, the first stage is called as steatosis, stage 1. Next, what happens? On the fat deposition, it starts inflammation. Because of the inflammation in fat deposition cells, we call it steatohepatitis. पहला क्या था? Steatosis. Second is steatohepatitis. And finally, it is the steatofibrosis, also called as cirrhotic stage. This is a Linac cirrhosis. Linac cirrhosis. Okay. Now what happens? In steatohepatitis, one of the very important body is called as Mallory-Denk bodies. Often they stain positive with cytokeratin. 8 and 18 is positive. And a typical mnemonic for Mallory-Denk body is weight in PHC. How to go through this mnemonic? Actually, alcoholic person supposedly has pain in abdomen. He goes to PHC, but have to wait there. To wait in PHC, Wilson, alcoholism, Indian childhood cirrhosis, alpha-1 antitrypsin deficiency, primary biliary cirrhosis, and hepatocellular carcinoma (HCC) are the main finding of the Mallory-Denk bodies. Mallory-Denk bodies. The third stage is steatofibrosis. Is also referred to as Linac cirrhosis. Linac cirrhosis. Remember, PSC is seen with ulcerative colitis. This is also one important information. And atypical Pianka is the antibody you see in PSC. What is PSC? Primary sclerosing cholangitis. In liver tumors, remember, the benign tumors are hepatic adenoma and cavernous hemangioma, but more common is cavernous hemangioma. In the primary tumor of liver, the main etiology is alcohol, non-alcohol, metabolic like alpha antitrypsin deficiency, hemochromatosis, and Wilson disease. PBC, PSC, increase in estrogen usage and aflatoxins. The main tumor marker of the HCC is alpha fetoprotein, but also is PIVKA. PIVKA stands for protein in vitamin K abnormality. Okay, the main IHC for this is glypican and hepatocyte paraffin 1. Very important is difference of HCC and a typical variant called as fibrolamellar variety. This variety means a collagen is between the malignant liver cells. It should not make a lot of difference, but it does. What happens? HCC has a poor prognosis. This variety has a good prognosis. Age of HCC is around 60 years of age. This variety is in younger age. HCC में male female ratio is 2 to 3:1. In variety it is 1:1. AFP very high in HCC, almost normal in a case of fibrolamellar varieties. Okay, this is what you see in HCC actually. In nerve system, I believe that these are the crystals that you should know. In the calcium oxalate, you see the envelope shaped crystals. Uric acid and calcium oxalate both are in acidic urine. In alkaline urine is triple phosphate, and look at this coffin lid appearance. This straight line, you think straight line. This is a coffin lid appearance. ये वाला. It's a coffin lid appearance. तो देखो what is it? It's a straight line दिख रहा है ना? It's a triple phosphate. Correct? Calcium oxalate. Correct? And this is a uric acid crystals. चलो. Next is the finding you expect in nephritic and nephrotic syndromes. देखो. The most common in a child among nephritic syndrome is a post-streptococcal glomerulonephritis. It shows a typical finding in the EM as humps. In the FM, it shows starry sky appearance, and among all disease, this has a maximum proliferation, PSCM. So in the PSCM, I'll just ask you to remember one word. It's a subepithelial humps. Just this is what is important. ठीक है? अच्छा. Next, you should know in IgA, ये सबसे easy है. You know why? IgA में mesangium, mesangium, mesangium. इतना easy है ये. Third is RPGN. In RPGN, in light microscopy, they show crescents. And crescent is a multiple times repeat question. Crescents. Very important. Look at the crescent also. देखो. This is a RPGN. In the RPGN, I hope you all can appreciate this is a kidney. And in the kidney, this kidney shaped crescent. ये crescent आया? The moon-like crescent. This also is a moon-like crescents. And this is a flea bitten kidney because of very high blood pressure. Very high blood pressure. This is a PSCN. Look at the humps. Starry sky appearance in the FM. दिख रहा है starry sky? अब दिख रहा है ना? पूरा star की तरह दिख रहा है. In this dark night sky, it's starry sky appearance. This is a hump below the podocytes, and hence sub-apical humps. This is not very important. Just leave it this around. Okay. Let's now move to the finding you expect in nephrotic syndrome. In nephrotic, what you expect is the name is minimal change disease. खुद का नाम रखा है उसने minimal change disease and has no finding in LM, no finding in FM. The only finding you expect is effacement of food process. In membranous, name is membranous. So something should happen to membrane. What happens? Diffuse GBM thickening happens. Okay. They often shows granular deposition. The main finding is effacement of food process with a subepithelial deposition. To remember, effacement is a property seen in the minimal change disease also in the membranous. FSGS का full form होता है focal segmental glomerulosclerosis. अब किसी ने नाम रखा है sclerosis, तो at least we should say this word. What is sclerosis? Fibrosis. So if you see fibrosis in the kidney, it has to be FSGS, right? It also says same finding. Effacement is in the minimal chain also, MGN also, and FSGS. And what is common about all the three? Nephrotic syndrome. So in the electron microscopy, minimal change, membranous, FSGS, also same finding, effacement. Difference is In membranous, we also see the subepithelial humps, and FSCS में we just see effacement again. Chalo. Alport syndrome is again very important. Alport syndrome is X-linked dominant more than X-linked recessive, but can also be autosomal recessive. The main defect is the collagen defect, and collagen lies in base membrane, because of which the GBM becomes thin with foam cells. There is no finding in the FM. In the EM, they show very important basket weave appearance. Basket weave appearance. The typical triad, how this question is often given to you, is hematuria with anterior dislocation of lens and sensory neural hearing loss. A typical triad of Alport syndrome is hematuria, matlab kidney issue, eyes issue, ENT issue. Eye, ENT, and kidney issue is called as Alport syndrome. Clear? Look at the minimal change these. यहाँ पर I've given you a normal appearing kidney biopsy, and on the right side, what you all see is this is the normal podocyte. ये normal image है. This is MCD. Lower image is MCD. It's showing you normal foot process. On the lower side, it is effacement or flattening of the foot process. Effacement or flattening of the foot process. This one is FSCS, and what you see here, this is fibrosis. This red pink area is fibrosis. And so the name is focal segmental glomerulosclerosis, fibrosis in the area, FSGS. In the renal tumors, the two tumors is often important and is often asked. One is clear cell cancer and one is papillary cell cancer. Remember, the most common etiology for RCC is smoking. Most common, okay? Clear cell cancer is the overall most common and is 80% of all the RCC is clear cell tumor, okay? PCT, यहाँ पर DCT, VHL in clear cell, MET gene in papillary carcinomas. Chromosome mutation here is 3p, यहाँ पर 7. Both of them have intermediate prognosis. Both of them have intermediate prognosis. Okay. Other name for papillary is chromophilic. Very importantly, when you get a case of clear cell cancer, it must show you what? Clear cells. And what do clear vacuoles contain? Glycogen and lipids. But if it is papilla, it's a papillary cell carcinoma. So, clear vacuoles है clear cell cancer. Papillary है papillary cell carcinoma. Most common among them, clear cell. PCT से clear cell. VHL mutation, clear cell. Which chromosome? 3p chromosome. 3p. P means the short term. P means short term. And here comes the clear cell tumor. This is a proximal tubules, and all the tubules have clear vacuoles and has becomes a clear cell carcinomas. Now you do CNS tumors. In the CNS tumors, remember, when you come across a tumor called as glioma, the common IHC for all glioma is GFAP, glial fibrillary acid protein, gliomas. Okay. In the glioma, the tumor can come from the astrocytes. The name is astrocytoma. It can come from oligodendrocytes, oligodendroglioma, and tumor can come from the ependymal cell, ependymoma. अब देखो, in every brain tumor, you must know grading, where grade 1 is benign and grade 4 is malignant. If something is benign, it is a better prognosis. Grade 1 का नाम है pilocytic, grade 4 का नाम है glioblastoma multiforme. Grade 2 tumor has a typical biopsy finding called as fried egg appearance. This question was asked in the January FMG question. Fried egg appearance is the finding of oligodendroglioma. Okay, site is frontal lobe and calcification very common in oligodendroglioma. In ependymoma, it's a grade 2 tumor. In ependymoma, it's a grade 2 tumor. Okay, it is site is spinal canal, and this is often in the fourth ventricle. In microscopy, it often shows rosettes, which can be true or a pseudo. It can be true or a pseudocytes. Now remember, when you talk about the brain tumor, how to remember the names? A tumor can come from neurons, a tumor can come from glial cells. It can be macroglial cells or can be microglial cells. Macro is of three types: astro, oligo, and ependymal cells. So tumor name is what? Astrocytoma, oligodendroglioma, and ependymoma. Ependymoma shows both results, true also, pseudo also. यहाँ पर क्या मिल रहा है? Friedreich appearance. Okay. Now coming to the other type of tumors. Apart from glioma, a tumor in the brain can also come from the brain sheath. What is that? Meninges. The tumor name is meningioma. They often are attached to dura mater and they show NF2 mutations. A typical finding of this meningioma is that the tumor will have this blue color deposition and they're called as Samoma bodies. Okay, Sam body is seen in PSM, paprikastoma, cirruscarcinoma, and meningiomas. Okay, clear हुआ meningiomas. Next, we move to the medulloblastoma. This tumor is not coming from medulla. तो obvious question बनता है. The tumor comes from cerebellum. The tumor has a typical origin of primitive neuroectodermal tumor. Primitive neuroectodermal tumor. PNET कहते हैं इसको. It's called PNET. Okay. Primitive neuroectodermal cells, they can become nerve, but on mutation they'll change to a PNET. All PNET, they have same microscopy called as Homer Wright pseudo rosette. In this, a dark blue cells have a center space filled with neuropil. Okay. Next is a peripheral nerve sheath tumor. It comes from Schwann cells, and so the name is called as schwannoma. ठीक है? It is having a NF2 mutation in which the main origin is 8th nerve more than the 5th nerve. It is vestibulo-auditory nerve. Microscopically, it shows two types of areas. Some area which is more cellular. This whole area having more number of cells is called as Antony A area. And those area with less cell is called as Antony B area. The area of Antony A, which has a typical cell arranged like a palisade, 1, 2, 3, 4, 5 straight line. This body is called as Verroque body. They've asked you Antony A, Antony B, Verroque. All of them are seen in which tumor? It is called as schwannoma. Achha. NF2. This is having on chromosome number 22q. They show miss-me finding. Multiple inherited schwannoma, meningioma, ependymoma. So NF2 mutation shows multiple inherited schwannoma, meningioma, ependymoma. Miss me. And I think you all will miss me after the class because I have taken so much pain to discuss everything possible till now. I have not even stopped speaking. तब से 2 घंटे से बोले ही जा रहा हूँ. Just that you will learn everything. This video को you can watch once and twice. एक बार सुन के अगर बहुत सब कुछ दिमाग में नहीं भी गया होगा, second time you see this in 2x speed, सब जाएगा दिमाग में. देखना. And don't stop till the time you have reached this step. I'm telling you, you watch it again. Okay? देखो. Next is this is the NF2 mutation is miss-me, multiple inherited schwannoma, meningioma, and ependymoma. Now is the GI. Now in GIT, we should first see the adenocarcinoma of stomach. What happens? Two types of ulcer are seen in the adenocarcinoma. It can be a benign ulcer. It can be malignant ulcer. Benign ulcer is formed due to peptic ulcer, whereas malignant ulcers are seen in adenocarcinoma of stomach. Often in a diffuse variety of adenocarcinoma, they don't find ulcers. In diffuse variety, they don't find ulcer. They form a thick, rigid stomach. It is called as linitis plastica. The name is linitis plastica. Okay, linitis plastica. Gist is gastrointestinal stromal tumor. The origin of gist is interstitial cells of Ghazal. It is also called as pacemaker cell. Very frequently asked question mutations. They show c-KIT, PDGFR alpha, and the best IHC for this dog1. But remember, among mutation, it is c-KIT, PDGFR alpha, and it is SDH loss. There are three mutations often seen in the gist, okay, which comes from the pacemaker cell of intestine. Treatment is often a chemotherapy, imatinib, else you have to reject the tumor, resection. Else we have to reject the tumor is resection. We now move to the intestinal malabsorption syndrome. It is called a celiac disease. This disease often happens due to hypersensitivity to gluten containing foods. And gluten is in bro, BROW, where B is barley, rye, oat, and wheat. Surprisingly, even a suji, or rava, or a semolina, which are same thing actually, they all also come from wheat. So these also are not safe in the celiac. This was asked in this January FMG again. Remember, rice is safe. Rye is not safe. Rice is safe. Rice pulses ये safe होते हैं. They are seen in those patients who have a typical HLA of DQ2, DQ8, and B8. In the biopsy, what should happen is this is a villi. ठीक है? If the villi are lost, flattening of villi, we call them celiac disease. This all crypts can be there, but villi is absent. Now that's not. Crypt is not absent. Crypt is not absent. What is absent? Villi is absent. Loss of villi with crypt hyperplasia is a finding of celiac disease. Okay, it's finding of celiac disease. Okay. The main antibody these patients often show is anti-gliadin antibody, which often cross-reacts with skin antigens, anti-TTG antibody, and anti-endomysium antibody. Anti-endomysium antibody. Very commonly, they show a typical rash in the body. Rash is called as dermatitis herpetiformis. They increase risk of autoimmune disease and they also increase risk of T-cell lymphoma. They also increase risk of T-cell lymphomas. Because it is due to gluten, the best treatment is avoid gluten in the diet. Okay. Next, we move on to Whipple's disease. The main problem of Whipple disease is Trophirema whippeli. यहाँ पर this is a villi. After infection of this small bacilli you have drawn here, what happens? Macrophage will engulf this, and this macrophage would compress lacteals. Because it compress lacteals, lacteals are for fat absorption. Fat is not absorbed and hence leads to fat malabsorption. It leads to fat malabsorptions. Okay, so fat malabsorption is the finding seen in Whipple's disease because they often get absorbed from the GI into blood and can go into brain. The brain can lead to seizures, dementia, and can enter joints also, causing arthritic pain. So if you get a question on a malabsorption of fat, steatoria hai, with a dementia or pain in the joints, go towards Whipple's disease. This is how the Whipples look like. Look at the macrophages, which often are pass positive, and they also are diastase resistant there. Diastase resistant there. Very, very important topic is a polyp. Very, very important for you. Okay. Polyp is of two types. It's a mucosal proliferation, as you all know. It can be benign polyp or can be a malignant polyp. A benign polyp is HHI, hematomatous, hypoplastic, and inflammatory. Malignant polyp is only one. It's a adenomatous polyp. Among the hematomatous polyp, which is very frequently asked to all of you, it is A, juvenile, and B, it's pure sugar polyp. Juvenile polyp, it is seen in, remember, J hai R, JR, PJ. So JR, juvenile polyp, rectum. PJ, pure sugar, jejunum. ठीक है? Less than 5 years, so juvenile name है. Pure sugar is seen around 11 years of age, but can be seen at any age. The most common finding, how do you expect this question of pure sugar polyp, is a perioral hyperpigmentation. The moment you say this word, perioral, bas answer ban chuka hai. It becomes a case of pure sugar polyp. If you get multiple polyp, they often, देखो, juvenile polyposis syndrome, pure sugar syndrome, both are multiple, both are dominant conditions. This is seen with SMAD4 mutation, it is seen with STK11 mutations. Not very important. At least remember, that juvenile polyp, they show large glands. Okay, and what do this syndrome shows? This shows a typical arborizing pattern. This one shows a typical arborizing pattern. Large glands, juvenile polyp, arborizing, tree-like pattern. Arborizing pattern matlab tree-like pattern is the finding of Piyush-Jaghar syndrome. Adenomatous polyp, in microscopy they show dysplasia. Remember, the malignancy is proportional to size of the polyp. Jitna bada polyp, that is the risk of malignancy. The three patterns of polyp: tubular, matlab tube-like glands. These are glands like a tube. ट्यूब कहाँ दिख रहा है सर? देखो ये ट्यूब है ना, टेस्ट ट्यूब होता है. If I cut it from center, this whole round area is what you see in the cross section. Same round is being seen here, and it's tubular like glands. Okay. Then villus. Villus is more invasive. How to remember? Villus is the villain. Villus is the villain. So more invasive is the villus polyp. Okay. And a combination is called as tubulo-villus polyp. Okay. In this polyp, if you get more than 100 in number, we call them familial adenomatous polyposis, FAP syndrome. They often are present on the APC gene on chromosome number 5 long arm. APC gene on chromosome number 5 long arm. APC on chromosome number 5 long arm. ठीक है, देखो familial adenomatous polyposis syndrome, autosomal dominant, APC mutation, number of polyp more than 100, and they often show perioral hyperpigmentation. The two syndromes of FAP, one is Gardner syndrome and one is Turcot syndrome. Gardner and Turcot कैसे याद रहेगा? Gardner makes food, तो FAP के साथ osteomas, odontoma, teeth वाला odontoma, okay, and desmoid tumor, FOOD. So if you get Gardner, he would make food, food बनाएगा नहीं, but food grow तो करेगा ना, food. And Turcot को turban, brain tumor, turban tumor, brain tumor. If you see brain tumor, Turcot syndrome. If you see us finding of FAP with osteoma, that's a Gardner syndrome. One more thing, this is a juvenile polyp. Why? Look at the large glands. And what is this? Piyush-Jaghar polyp. Why? Look at the arborizing pattern. Sir, arborizing matlab tree-like. Sir, tree is where? Look at the first branch of a tree, second branch of a tree, third branch of a tree. Arborizing pattern. ठीक है? Arborizing pattern. अच्छा. One very important thing is HNPCC Lynch syndrome. It often occurs due to MSH and MLH mutation, which is microsatellite instability. So if you get the word like this, MSH, MLH, MSI, these all are linked to the HNPCC, which is nothing but a Lynch syndrome. What is Lynch? Hereditary non-polyposis colon cancer. ये है Lynch syndrome. Hereditary non-polyposis colon cancer actually is a Lynch syndrome. ठीक है? अच्छा. Finally, I move to the Men's syndrome. Okay. Finally, I move to the Men's syndrome. Men's syndrome is multiple endocrine neoplasia. If one gene is present in multiple of the cases, if one gene is present in multiple of the tumors, if that gene gets abnormal, all tumor will occur. In endocrine origin, it's very common to have this. These tumors are multiple and they occur together. How to remember men? First is name it men 1, men 2A, men 2B, nowadays called as men 3. Men 1 gene is men gene. 2A, 2B, RET red gene. How to remember? 2. 2 है ना तो डबल P सिपल. 2 है तो डबल P सिपल. Men 1 में 3P. Men 2B में 3M. What is 3P? If you get a tumor of parathyroid, pituitary, pancreas. Parathyroid, pituitary, pancreas. ये है 3P. Parathyroid, pituitary, pancreas is the 3P. If you get Melry thyroid carcinomas, म्यूकोसल न्यूरोमास एंड मार्फन सिंड्रोम लाइक फाइंडिंग मार्फिन एंड हैबिटस, ये होगा 3M। याद हुआ 3P 3M। 3P मतलब पैराथायराइड, पिट्यूटरी, पैंक्रियास। 3M मतलब मेलरी थर्ड कार्सिनोमास, म्यूकोसल न्यूरोमास, मार्फन एंड हैबिटस। एंड इफ इज 3P 3M याद हो गया, लेट्स बी हैप्पी। व्हाट इज हैप्पी? हर्स्ट्रम, amyloid, pheochromocytoma, parathyroid, and Melry thyroid carcinoma का Y. The Y of this Melry thyroid carcinoma Y. It is Hirsch, HAPPY. Happy. Hirschsprung, amyloid, pheo, parathyroid, Melry thyroid carcinoma is a happy. So 3P, 3M and happy. Questions क्या है? Men 1 में men gene, 2A 2B red gene, Sipple is 2A, Wormer is 1. What is the most common P in pituitary? Again P, which is prolactinoma. Most common P is prolactinoma. Which syndrome or which thyroid cancer occurs in men's syndrome? Answer is Melry thyroid carcinomas. Melry thyroid carcinomas. Men 4 is a very new term. Men 4 is almost like men 1, but they don't have a men mutation. They often have a typical mutation of a CYP gene, which is P21, 27, 57. Just remember, if you get a men 4 without a men gene mutation, if you get a men 1 like finding without a men gene mutation, we can't call this men 1, right? And hence what's called as men 4. And hence what's called as men 4 there. Okay? With this, we come to the conclusion of this one short session. Honestly speaking, I have worked hard on this. I've tried to take out all the questions of the FMG in last few years and picked up those topics which I feel from the main notes, which I have taught you enormously in level, how I can decrease the amount. I felt these are the topics that if you can go through at the last moment will help you enormously. Will really help you enormously. Okay. Perseverance is the hard work you do after you get tired of doing the hard work you already did. That means be consistent, don't stop. If you are consistent, no one can beat you. Be consistent, do not stop. You are feeling tired, just thoda aage badho. Exam is very near. In a few days, everything will be over. Don't stop right now. Success is the not the key to happiness. Happiness is the key to success. If you love what you're doing, you will be successful. And I'm very sure you all love reading it. Do it always. Continuous effort, not strength or intelligence, is the key to unlocking our potential. Effort करना है, strength तो है ही. Don't look back. Ahead what lies is your notes, your revisions, your multiple revisions going ahead. This time, no distractions. Only God and me and my dreams. That is our motto. No one can at all change us. Success, the struggle you are going today, is developing the strength you need for tomorrow. And tomorrow, when you come to the professional career of MBBS, this whole hardship you're going through, staying in different places, reading every day, same thing again and again, will help you to move ahead. You know how hard work lies ahead. Doctors are not having an easy life, but because you are struggling right now, it'll give you strength to come across that. So don't worry, guys. In just few days, everything will be over. And with this, that like I'll just go with half effort does not produce half results. It was no result. Now, because few days are left, work hard, continuous, work hard, hard work, and that is what will give you the best result you're all hoping for. I'm very sure this time there's no distractions. There is God, there are you, and yes, there are all your dreams there. Okay, this is all PDF is already uploaded in my Telegram group. I have not written anything there, so there's nothing to share. It's all PDF. I just wanted you to just listen to me very carefully. There's nothing to upload again. I've hardly done anything in the PDF. I just underlined this, so I don't think there's any reason for uploading this again in my Telegram group. But it's already there. Please download it from there. Take a wonderful printout for yourself. As you, if you want to watch this video again, one small request, guys, that once the video is over, once the live streaming is done, to come back after 10 minutes and put your valuable comments in this video. It really helps us, all of us, to keep motivation and move ahead as you move, as you just come back. So just take a rest of 10 minutes, and when you come back, and just put a comment as to how do you like the video, and please do share the videos to your friends so that all of them can revise in just 2 hours entire pathology. And I'm very sure a lot of questions will come from this topic and you will be winner from that. Okay, take care guys, God bless you all, wish you all the best, stay in touch and stay happy, but do start studying again. Goodbye.